Okay, I think we're going to get going this morning. My name is Len Calabrese, and I think I know just about everybody here in the live audience. This will be repurposed on our website. I'd like to welcome you to Rheumatology Highlights Reports, Best Practices in Rheumatology. So we've kind of broken this down into, just some select topics, and I'm going to ask Dr. Rigby to lead off this discussion as to what he thought was kind of interesting in the area of RA and comorbidities, and then Elaine will follow. So.
Great. Thank you, Len, and it's a pleasure to be here at the Cleveland Clinic. And my talk is laid out in with the following learning objectives. These are learning objectives that I think you would bring to every meeting you go to. What can you extract from that meeting or the information that's presented that would really impact on how you practice, either in assessing patients or treating patients or deciding what's the best choice of a medicine to use for a particular patient? So you can read these. And I really want to really emphasize that I really tried to focus on the most current stuff that has not been presented ever before. So my presentation layout as follows. There's two basic chunks of material that are coming your way. One is in the first, three are emboldened because they'll be coming to you as an aggregate. One is dueling DMARDs, the comparison studies. And the second is aggressive therapy in early RA. What does that tell us? And I think there's some really interesting results that came out of this. And finally, the question for all the rheumatologists in the audience is that about long-term efficacy. So in our my first bullet, the dueling DMARDs, I think the AMPLE trial is the one that's been the most in the news. The AMPLE trial, as you recall, was subcutaneous Abatacept versus Adalimumab, randomized controlled blinded study using subcutaneous drugs, subcutaneous injections, in a methotrexate inadequate responder population. And this data has been published, but this is going to lead into what I'm subsequently going to talk about. What's interesting is that 82% of the people completed this trial. One of the take-home points was Abatacept and Adalimumab were equivalent, both in their onset of action and efficacy. There are a few more serious infections in the Abatacept arm in the first year. But what was presented at EULAR is the follow-up studies. And the follow-up studies represent all the post-hoc analyses. Now remember, the study was not designed to address these, but they had a very large group of patients, and they had a lot of analysis that they performed. So the first thing I want to emphasize is that, remember, these drugs were equivalent in terms of DAS, CDI, SDI, or Boolean measures. And also, if you add patient-reported outcomes, so the RAPID-3, the HAC, you got exactly the same kinds of results, equivalence between the two agents. The second thing is that there were equivalent radiographic outcomes. There was no difference. So as we all have been sort of raised on the notion that TNF-Antagonists prevent radiographic progression even in the absence of controlling inflammation, here we have a drug like Abatacept, which should not be working through those direct effects on osteoclasts, that seems to have equivalent activity. And finally, at 2 years, it really didn't matter how long you had the disease, what gender, et cetera, et cetera. They could find no really significant differences in what predicted the outcome. So I think we're all left with, kind of mysteriously, we're all left with that two entirely different drugs with different mechanisms of action, studied as rigorously as you can imagine, ending in a dead heat. And what's interesting is how that will change your own prescribing patterns, how it changes our prescribing patterns, and I think we all have to think about that going forward. And I don't know what it's like in Ohio, but in New Hampshire and Vermont, the payers oftentimes make the decisions for us. My second issue I wanted to talk about was a fascinating trial, I thought. It was called the AVERT trial. And this was a group study that Paul Emery put together, and it kind of builds on a previous study he did with etanercept. But in this trial, he took early rheumatoid arthritis patients who had never been on methotrexate, never been on any Abatacept or whatever, and randomized them in this ACPA positive group, so anti-citrulline positive antibody positive group, so a coherent group, and they randomized them to 3 different treatments for 1 year. This this is different from the PRESERVE trial, where there was sort of a relaxation of therapy, where you went from etanercept weekly to etanercept at half dose weekly. So my first question is, at 1 year, I want to ask you all how much, if you took all those patients that were in remission, okay, at 1 year, and then you stopped their drugs, at 1 year, what percentage of these patients would remain in remission 1 year later, off of methotrexate, off of Abatacept, off of combined therapy? So I think you're allowed to vote.
Making a mental vote.
The correct number is 40 to 60%, and I'll tell you about that data, and which is actually, I thought, very striking. And so let's talk about this result. The percentage of patients that remained in DAS28 remission were 45% in the methotrexate-only arm. Remember, methotrexate for 1 year, then stopping, which I don't think any of us do. The patients that got Abatacept only, 42.5%, and the patients that were on combined therapy, 61%, 60.9%. So this is very striking. It's much higher for methotrexate than I ever would have thought. What's also very powerful is that this is not a durable response at 1 year. If you look 6 months later, it all falls off, the response rates, the remission rates all fall down to 7 to 14%. So in other words, it looks like we can probably relax if this is predictive of anything, it does look like we could probably relax our therapy, no matter what it is, in patients that have been in a good long-term remission. Now, I don't know about you all, but this would feel kind of a guts ball play for me. I would not want to do this if somebody was in methotrexate on a beautiful remission, because I know how safe methotrexate is. But I do want to remind you that in the etanercept withdrawal trials, in a very similar study design, the remission rate at 1 year was also about 50%, either with methotrexate or methotrexate with etanercept. So I think that in 2 separate trials, with different drugs albeit, or different designs, the long-term remission may be possible in a certain subgroup of patients. And in this particular trial, they thought that people with shorter disease activity seemed to have a better remission rate. So I thought that was a quite unexpected outcome, and I'm not sure whether it's going to change any of your practice, but that's what I'm going to ask you right now. So
this is a mental gauge here for everyone. Go back to that, and I'm going to respond here in kind here to the panel as your surrogates. I mean, and I'd like to start with this. So the last trial, the ABA methotrexate. First of all, I agree with you. I don't think that discontinuing methotrexate is a gambit that anybody is going to do immediately upon getting into something like a DAS remission, which is far from being cured of your disease. It's
right.
just it's a pretty good marker, but it's not that great. Secondly, recognizing this was a unique group of people. These are early disease, and I think everything that we're learning is that, you know, that the taxonomy of RA, it's a different disease early than a different disease late. But where I think the money is, literally and figuratively, is for us to develop strategies that we can, you know, kind of bag out of the biologics for 6 months or 12 months. So you think of how much savings that could offer, and whether this has any downstream effects. You know, so the hot topic seems to be today of, you know, when can we discontinue biologics? EULAR tells us, you know, steroids, then biologics, then non-biologic DMARDs, at least in their recommendations. So, yeah, I think that that's kind of pushes me a little bit toward that notion that maybe we can take the break on biologics, and, you know, if there was no cost factor, maybe it wouldn't be that important, but I think it is.
So for me, I think the whole concept of stopping DMARDs is not in my toolkit at all. When I start them, I tell them all the side effects, and I think they're going to be on it for a long time. What is driving that now is a lot of my patients are asking to stop, or they come back and they said, you know, I've stopped and I still feel well, so what do you think? So I think patients are driving me to make this decision many of the times, which I think is interesting because it's not coming from me. So they either let their prescription lapse or they feel very adamant and they just want to know what the side effects are if they stop, and they stop.
Right.
And I am dealing with when they might start back. The second thing that I find interesting is I do a lot of work with dermatology. I have a multidisciplinary clinic, and they always do intermittent therapy because in the psoriasis world, they can see when the skin comes back.
Right.
So they're very comfortable with this. In fact, they think the way that we treat is crazy to put someone on long term. So.
Yeah.
You know, so I would have a question of the 60% that appeared to have continued remission after Abatacept, after it was stopped for a year. I wonder if that's somewhat predictable or linked to their particular disease. In other words, can we develop a biomarker that says this is the person that actually we're going to induce a remission, they're going to stay in it for a while? Because that would really be fantastic. You'd want to put everybody through the potential increase in symptoms and discomfort if you know that only somewhat like a half will actually maintain remission. But if you really can predict who's going to have these durable benefits, then you don't have to subject them to the biologics for that long period of time. The other question is whether or not the remission might be maintained even though the biologic was stopped if you continued the methotrexate. And I guess the other
Which is
point
the way
that
most of us would be doing it.
yeah, and the way we would think about it. And the other question is, do their symptoms return only, or do they actually have radiographic progression? And I would probably bet that radiographic progression is arrested, and that actually it's symptomatically that return, and it seems as though these biologic agents really can affect osteoclasts and have benefits even in some patients who are really continuing to have swollen joints and painful joints. So I think there's a little bit more information that we need, but I'm optimistic that this could actually mold our practice in the future.
You know, the other bit of data in those first two abstracts was the Abatacept monotherapy, which we haven't seen a lot of, and you know and I think that if you kind of go up to 30,000 feet, there is growing data for every one of these biologics, including rituximab as monotherapy, Abatacept, obviously tocilizumab, which has been touted for this, and tofacitinib. We've known about TNF inhibitors. I think that the monotherapy card is increasing in desirability as we examine people who have either defaulting on their methotrexate or having a lot of side effects. So I'm kind of leaving that there, but that was one of the take-homes I got from the Abatacept. I mean, wasn't statistical, but clearly it was methotrexate, ABA combination, and it's an option.
Yeah. So I think the two basic ideas that are being dealt with are, one is that induction therapy, does that induce a long-term remission? And I think we can all agree that it does not, so that the induction therapy with the goal of putting somebody in a drug-free remission does not happen.
Not in 100.
Not in 100 patients, but at 1 year, it's pretty darn good. 60% with combination therapy, that's number one. And the other question is, how would would you feel if somebody had failed methotrexate or had an inadequate response, and you then put them on Abatacept, Adalimumab, Abatacept, whatever, and 1 year later their disease is absolutely in absolute remission, would you feel comfortable stopping the biologic, or would you feel more comfortable stopping the methotrexate, which had not gotten you to that point? And I think those are open questions.
That's for the next meeting. All right, move on.
Let's
Okay.
work on it.
So do we want to take this?
I think we kind of beat these up.
Okay. Okay, so the next question is long-term efficacy, who stays on biologics? So I think all of us know the biologics are very effective, and we all have our own preferences and choices, and we all get comfortable with certain biologics. But most of the time, we use those biologics with not looking at how that patient feels at 3 months, 4 months, 6 months, 12 months. We don't put them on the biologics thinking about whether they're going to stay on it 5 years later. And as we get more and more concerned about cost, hoping that the biosimilars maybe will have some impact, one of the questions always is, who stays on the biologics? And if you're in a registry database from Canada, they've been very active about looking at this. This is Denny Choquette and their Rheuma database. And what they show you here on this slide is the various TNF antagonists, as well as Abatacept in a methotrexate inadequate responder, and a TNF-IR patient population, TNF inadequate responder population. And they show you the survival, and remember, this is a registry, so this is not a randomized trial. They tried to match the patients for disease activity at the time of entry into the registry. But I think what you can see is that the numbers range from 64% with Abatacept with methotrexate inadequate responders, and all the TNF antagonists come out at about the same level. And there's really no significant differences with a methotrexate inadequate responder or a TNF inadequate responder. And I think it's kind of interesting. This is the first time I've ever seen Abatacept used against the TNF antagonists in this way. And again, I think it does pretty well. I also am pretty surprised that there wasn't a difference in the TNF antagonists. I know that various TNF antagonists have made claims about being more durable in their effects, but there was really not a significant difference. And then I highlight the Italian registry, which also showed no difference with long-term efficacy with the various, the typical 3 TNF antagonists that are used. So.
Do you think the Abatacept number is really different in the methotrexate inadequate responder?
I don't think there's any difference. I think the numbers were very small in that patient population. It was much bigger, as would be found in the United States. Much more TNF is used as a first-line treatment of a methotrexate inadequate responder.
You know, Elaine and I were talking to some people from a biotech firm last week, and they said that some of the adherence continuation data is very country specific, and that they differ radically for their one product in different countries. Yeah. Obviously, this is Canadian.
Yeah.
So, I mean, probably not payer influence there as much as in the United States, so your copay goes up and you're going to be out of there, and so I think it makes a difference.
Right, and the other part of that is that you don't get a biologic in Canada unless you failed specific criteria. And so, those are very, there's a little variation between provinces, but for example, in Toronto, you have to fail both 2 or 3 DMARDs to get onto a biologic. And that tends to be pretty consistent across Canada. Now, the other part of this was they pooled all their anti-TNF patients, and they looked at the rituximab patients in their patient population, and they looked at their survival as second-line or third-line therapy. And not surprisingly, rituximab does better in terms of long-term efficacy, not in terms of long-term efficacy, but long-term duration of therapy. And rituximab does significantly better than a TNF antagonist. Of course, this is not unexpected. You're already selecting for patients who have failed the TNF antagonist to get into this arm in the vast majority of patients. And this result is actually completely in line with the British registry, which showed that second-line rituximab was superior to TNF cycling, a second TNF antagonist. So I think what we have to conclude is that 2 different countries. You could argue that Canada and England have a lot of similarities. I think the people in Quebec would take considerable exception to that. But you know, who consider themselves France more than anywhere else. Okay, but you can think about that. Now, one of the areas that is just extraordinarily interesting, and I think this is relevant not just to rheumatoid arthritis, but it's relevant to how we use these drugs in psoriatic arthritis, ankylosing spondylitis, and everything, is this notion that adalimumab is immunogenic. This is a fully human antibody. And there have been some studies that have been coming out about adalimumab being immunogenic. And in contrast, etanercept has been cited as being relatively non-immunogenic. So here's a large study syndicate. This is from many centers that pooled over 400 patients in each arm, starting on adalimumab or etanercept, and then followed up at 1 year. And they found anti-adalimumab antibodies in 25% of the patients at 1 year, and essentially 0 in etanercept arm. And then they said, well, what's the clinical significance of these, the absence or presence of these antibodies? And what was not surprising, or what was interesting, is that correlated with both lower drug levels as well as decreased clinical response measured by a delta DAS. So the delta DAS, if you had an adalimumab antibody, was about 0.8 units lower than if you did have an adalimumab, 0.8 lower than if you did have an adalimumab antibody. So what's interesting is that there is some clinical relationship. It's not huge, but what's profound is that there does seem to be an effect. And if you look at the patients that were not on methotrexate, 61.4% of the patients never developed an anti-adalimumab antibody. If you were, if you were on methotrexate, 61% had no antibodies, whereas if you were not on methotrexate, it was 43 or 44%. So what's interesting is that there is a subgroup of patients who can be managed with monotherapy in rheumatoid arthritis that don't develop adalimumab antibodies. The fascinating point of this is that this does not seem to be a problem in psoriatic arthritis and ankylosing spondylitis, where monotherapy with adalimumab is used without difficulty. But I think this does explain what many of us observed in the clinic, is that there are a subset of patients who go on adalimumab and start and do very, very well. Even on background methotrexate, you lose some of those. And I have noticed that, and I'd be very interested in other people's impression about this.
I mean, it's in the package insert from the day this drug was approved that methotrexate enhances its pharmacokinetics, and it's probably on the basis of this.
Yes.
I mean, I buy this.
Okay.
So what they're saying is that rheumatoid arthritis patients inherently have a greater capacity, for instance, compared to psoriatic arthritis patients, to recognize this agent. And the agent has been made to look and act like a human antibody, but maybe it's just not completely perfect. And it really is quite interesting to think about that. You can have, the immune system can at times recognize the difference between two compounds if they vary by a single atom, to tell you the truth. So some people's immune system can figure out that this is an imposter, and having an immune response to it, having antibodies to adalimumab, decreases the effective level of the agent and interferes with efficacy. The question is, what do you do operationally? And we don't really have the latitudes to keep advancing the concentration, the dose of the drug, and probably you wouldn't want to, because it would get increasingly expensive, and that we all know how often that occurs with infliximab. But I think being aware of that potential scenario may tell you that you're getting to a point where maybe you want to switch to a different agent.
Are adalimumab antibodies commercially available to anybody now?
There are
infliximab.
There are assays out there. I'm not sure.
Anybody in the audience doing anti-adalimumab antibodies?
Well, one other point I wanted to bring up is, adalimumab was studied as 40 milligrams sub-Q weekly and was really not found to add much to every other week, which argues that the patients that aren't responding to adalimumab, probably if they're making these antibodies, it really doesn't matter how much adalimumab you put into them. They're still going to neutralize it.
You may be right.
I think it's a work in progress.
Do you guys have a sense of, a lot of patients ask to reduce methotrexate. So it's like, how low do you go? Like, is 3 tabs once a week helpful to this kind of? Or
I'll throw in on that. There actually been some recent data on that. And if you go back all the way to the infliximab trials, it's somewhere in that 7.5 or 10 milligrams is anti-immunogenic. It's not like you got to treat like with a Blavovit.
Right, and all those trials, including the recent paper by Burmeister, are all using 24 weeks as their measurement point. So long term, we don't know, but probably if somebody's really intolerant of methotrexate, you probably can back off the dose to a more tolerable level.
Okay.
Okay. So this is a question: will this study influence your current practice?
Well, I haven't been able to get these antibodies, so it's not influencing it
I think,
at the moment.
well, one way you might think about it is, would you ever stop methotrexate in somebody who's on adalimumab?
It's a really good point, and I think that is a great deterrent at this point in time till we know more.
Okay.
Anybody have any comments on this at this juncture? We'll be happy to interact in that way.
So this may influence my practice, and so it sounds like when people voted that way, were they thinking that this would keep them on methotrexate? Is that what they're thinking?
That's the essay part of the.
The essay part.
That's the essay
Okay.
part. Yeah, you
So
have
we'll
to text
move
it
on.
in.
Oh, yes.
There's no available commercial measurements for anti-adalimumab.
Repeat.
So the question is, are there any commercial antibodies available for measuring anti-adalimumab antibodies? And the answer is there are commercial assays. I can't speak to the quality of them or anything else. I've not used them. For my own practice, lack of activity is lack of activity. So if the drug's not working, I stop the drug. Same, and that's also been my experience or my practice with infliximab. So in the last third of the talk, I'm going to talk about some comorbidities and rheumatoid arthritis. We're going to talk a little bit about biomarkers. So this is a patient I had just recently. This is a 58-year-old man who I started on adalimumab. I'm not trying to beat up on adalimumab today, but it just happened. I used adalimumab, and I started him on March 1st, and he had a background history of interstitial lung disease. And over the next 8 weeks, he became progressively short of breath. And I think you can see on this chest x-ray that he's got some subpleural ground glass opacities superimposed on a little honeycombing and some other significant interstitial lung disease changes. Okay, so this brings up the question about the safety of TNF-antagonists in rheumatoid arthritis-associated interstitial lung disease. Now, the Europeans have been talking about this, and again, I'm referring to a European League Against Rheumatism meeting. But I want to give you a little background, is that in the British registry, where they looked at all the patients in a TNF cohort versus a DMARD cohort that had interstitial lung disease, the rate of death was really no difference between the two arms. However, if you looked at the patients who died due to interstitial lung disease, the 21% of the patients who were on anti-TNF therapies were dying. The cause of death was felt to be the interstitial lung disease versus 7% in the DMARD cohort. And that's probably, and this has led to a bunch of studies looking at alternative agents, and there's been a previous abstract presented by the group at Leeds, and there's about rituximab, and at this meeting they presented another abstract, another group presented an abstract looking at patients with interstitial lung disease who are not randomized. One group got rituximab in an open label way, 40% of their patients, and the other patients got a TNF antagonist. And the mean change in DAS with both agents was about the same. But the take-home point for them in this retrospective study was that there was no change in lung function over the 5-year period in the group that got rituximab. I think this is, they didn't really present very carefully the information on what happened to the patients who didn't get rituximab, but I think in general most of us think that interstitial lung disease in these patients progress. So I thought that was kind of interesting. And the other interesting phenomenon is one that I think you've all observed here, is that when a patient has a prior history of cancer and they failed methotrexate therapy or had an inadequate response, what do you do? And I think oftentimes, for no clear reason, but probably because of the fact that TNF antagonists have been associated with lymphoma and have been associated with increased non-melanomatous skin cancers, there's a feeling that the TNF antagonists are not quite as safe in that patient population. So they went back and looked at a British registry. In the British registry, they went back, and remember, this is everybody in the United Kingdom who gets a biologic. They looked and saw what the patients with a prior history of malignancy were from 2008 to their follow-on point. And interestingly, in England, the same phenomenon, the United Kingdom, the same phenomenon has asserted itself there. 8.9% of the rituximab patients had a prior malignancy. It was 1.7% in the anti-TNF, so there'd been some channeling bias away from the anti-TNFs. And the baseline DMARDs was 4.2%. Now, the interesting point, and remember they don't have big numbers, is that both the TNF antagonist and rituximab were associated with a halving of the second malignancies. It was 0.55, so 55% of the 45% reduction from the rate of second malignancies seen in their DMARD alone population. So the question is, I think this is an open question, and I'm not sure this is going to change anything, But I think more data will be coming out of registries on this topic in the future. Now, there's two more data slides I want to present, but one is a unique study that only can be done in a place with single payers, and this is from Denmark, and this is where they took 52 consecutive patients who failed methotrexate, and they all were placed on Adalimumab, and then they did every single type of imaging that you could do. They got CAT scans, they got MRIs, they got CT scans, they did ultrasounds, they got radiographs at baseline and at 1 year. They also used the multi-biomarker disease activity score and wanted to compare the two and how they performed, or compare these various indices. So the first take-home point was that the median change in the biomarker score was apparent at week 2 and was relatively stable. So it fell by 25% within 2 weeks of starting the adalimumab and stayed there thereafter. And it's still not what I would call a low disease, it's not a big drop. Obviously, some patients drop more than others. The interesting thing is that by using any mean significant change that they tell by imaging, about 18 or 19% of the patients have X-ray progression. All of those who had X-ray progression had active disease by their MBDA, and two of those 10 patients that had X-ray progression were in remission at week 26. So the question is the MBDA useful in predicting X-ray progression? And I think, and the question sort of remains open about that particular point, because the question would be is that you wouldn't do the MBDA in everybody. You might just do the MBDA in somebody who's in a DAS remission to try to select those patients that might go on and have X-ray progression, despite being in clinically inactive disease.
Well, I think that is the question regarding this particular test, the MBDA. The use of this as a predictor of radiographic progression has just been, the SWEETFOT data has just been published in ARD. And I think as a baseline predictor, my critical appraisal is that it is the best predictor of future radiographic progression. This is a different story. Going from 63 to 48, that's still in the high disease activity category. We know that from the data on this marker that a good DAS response, a significant DAS response, usually drops by about 20-25% like it does here. We desperately need a marker or a predictor to get back to the first question that was raised up. Who is it actually in a real remission and a durable remission that we can save money and toxicity from? And I think these are pebbles on the pile. It's interesting. These are tiny numbers. But I think the part that is important is that, and I'm surprised it's only 2 in 10 in DAS remission.
Right.
DAS remission is not disease remission. That's a DAS remission. So I think it's interesting.
Right. I think the DAS remission point that you make is that many clinical trials, particularly from Europe, but also some in the United States and some registry data, suggests that X-ray progression is seen as many as 15 to 20% of the patients that are in DAS remission. So that patient who looks great in your office, 15 to 20% of them will progress. Now, that's not been my clinical experience, and I'd be interested in Elaine or your own experiences. Do you see much X-ray progression when people look clinically great?
Well, the question is how aggressive are they in imaging with methodologies that might be more complete and pick up changes that otherwise we might miss in the kind of images that we can get in our clinical practice.
Right.
I think that's important.
Right. Well, this is obviously a very aggressive imaging strategy. So the other question is if somebody does come in your office and looks like they're in DAS remission, Boolean remission, whatever, what does getting a MBDA add to that? And what was interesting, they had 15 patients were DAS remission, so remember it's 51 to start, so approximately 30%, 40% in DAS remission, good response rate. Of the 15, all had inflammation by MRI and or ultrasound. Again, not unexpected. We know how sensitive these techniques are. Power Doppler can see a lot of things when the joint doesn't look abnormal and it's not even tender. And then the other question is that 6 of that 15 had a high MBDA score, okay? So 6 of the 15 that were in DAS remission had discordance, and only 2 of the 15 were in an MBDA remission. So, that means that approximately of the 15, 6 had high, 2 had low, and the remaining 5 were intermediate. So I guess the question sort of always has been with the MBDA has always been, is this really add anything to managing patients or assessing patients when they're in remission? The usual argument is that one of its most effective ways to be applied is the patients who have a high global pain score, maybe the patients with secondary fibromyalgia, myofascial pain, depression, et cetera, or even somebody with bad spinal stenosis is going to have a high global. So the question is, what's the utility of that?
I think the other thing to mention, though, is that all of these scales seek to give us a more quantitative approach and earlier determinations on who is it that otherwise would end up with very severe disability. And they're so accurate, the way these scales have been developed, or at least quantitative. There may actually be a separation. We may be increasingly focusing on smaller and smaller units, and evidence of residual inflammation may be bad, but maybe they don't have an impact on quality of life and whether you're going to be able to walk or whether you're going to be in a wheelchair in 10 years. And there's some data that try to connect these more recently developed measures, but I think the data is really inadequate.
Right.
So we have to know what the threshold is. It's not going to tell you black or white disease is active and progressive, must treat more aggressively, you must do something. I think we have to have an idea of whether or not when it's really abnormal, maybe that's the time to be more aggressive, but these things are in flux still.
I'm going to try to keep us on time. I'd like to just take a summary point here, is that we are not satisfied that clinical composite markers such as DAS or anything are giving us a truly systemic definitive answer as to activity and remission. Yet biomarkers and imaging are still a work in progress, and I look for further refinements in this area, but it's an area that needs some work.
The other thing, last point I would make is, remember the MBDA was trained in basically a methotrexate, TNF-Antagonist world. Tofacitinib is shown to work, but it remains an open question whether the other agents, tocilizumab, rituximab, tofacitinib, this assay can be used.
Okay.
So I'm going to summarize with briefly the assessment of disease activity on MRIs. And whenever I get an MRI on one of my rheumatoids, I'm always astonished by how much I see. And the question is, how does that really impact on your clinical management or markers? And the answers are that it's pretty ambiguous at the current time. I think the most interesting paper of these, and you can see the bullet points here, the most interesting point was in a German study where they noticed that tocilizumab therapy seemed to improve overall bone density in their patients that had osteopenia and osteoporosis. And of course, tocilizumab would block IL-6, which is an osteoclast activating factor, and I think that may be perhaps one of the most interesting things about this is what's the generalized effect of tocilizumab on bone. So I'm going to do the take-home point summary. There's relative parity among the biologics in terms of long-term efficacy and safety. I think when you get to second or third line and other sorts of situations, you see unique events coming out. I think the other major point was the AVERT trial showing 1-year remission in 40 to 60% of patients, even if they had only been treated with methotrexate, but if you had achieved remission. I think the MBDA testing, it continues to perform. Of course, you tend to only see the positive data, so we'll wait to see how it is, but I know that there's been some uptick in activity. And I think the issue about MRI imaging really needs to be defined, and I think there's some very aggressive research programs to try to look at MRI and so forth.
So I just have a couple slides. So I'm touting the obvious. So we all know the detrimental effects of smoking and lung cancer. The question is this our responsibility in our daily practice, and why am I bringing this up? So I want to review smoking and rheumatoid arthritis. So over a decade ago, maybe in the year 2000, the ACR meeting reported the risk of developing RA was nearly double in smokers compared to non-smokers. Then subsequent analyses, meta-analyses, supported that this was worse in people that were rheumatoid factor positive. And then the headlines then went even further, looking at gene environmental associations. And if you had a relationship with HLA-DR, the shared epitope, your single copy would give you a relative risk of 7.5, and if you had a double copy, it would rise up to 15.7. Here's a past a EULAR abstract, not from this meeting, but looking at intensity of pack years associated with poor response. So now we also have data looking at the number of pack years that you use, the worse that your response could be from using an anti-TNF. So basically, in this particular abstract, up to 20 pack year history had a negative effect based on EULAR good response, S-die, C-die at 12 months. And then in this year's EULAR meeting, they looked at actually the act of smoking cessation. So what does that do to your practice and biologic treatment? So this was a very large 11,900 patients looking, separating into smoking history by whether you're a current smoker, a non-smoker, or that you've stopped smoking at some point. And they looked at the association between the causes of discontinuing a biologic therapy and your smoking habit were analyzed. And basically they found also that smoking might affect the responsiveness of biologics. But furthermore, stopping smoking actually would reduce the failure of biologic moving forward. So I thought some of these were pretty compelling. And I think as we are all very busy in our practices, sometimes we don't take the time. But I think the evidence is there that you might say that it's the primary care doctor or another doctor that might do some of this wellness prevention. But I thought it was just good to keep in mind. So anybody want to share their go-to plan for smoking cessation?
Yeah, we had some hands over here. Who has the go-to plans for smoking cessation? Lisa.
I offer either Chantix or bupropion.
So you prescribe and you feel comfortable.
Medications. Okay. Anybody have a relationship with wellness smoking strategy or anything? Or
In my hospital, we actually have a cessation clinic, so we can just refer and they take care of everything and try to watch to make sure that people
take care
are
of
compliant.
everything.
Well, that's my
Stress
illusion.
management.
But I just wanted to comment that also in my physical examination, I always note whether or not the patient has yellow fingers. Yellow fingers correlates with poor clinical response to intervention.
Yeah.
Also, if you have a functioning nose, it doesn't harm to say, do I smell nicotine?
Okay.
Yeah.
Dr. Khan, I agree 100%.
Yeah.
Okay.
Yes. Yes.
Well, there was a good study that showed the number one factor in influencing the patient's quitting smoking was the physician's interest.
Right.
And once we stopped being interested, the drop-off was great. So just showing your interest, and I always ask them if they're interested in talking about smoking cessation, and then I go into my little plan.
Thank you.
So hopefully this
Excellent.
stimulated you guys to start talking more to your
Yeah.
patients about smoking. All right.
All right.
So I'm just going to end with everybody is aware of the cardiovascular effects, subclinical disease in RA patients. I thought I'd take a little different abstract and look at stroke. So we talk a lot about ischemic heart disease, and we know a lot has been done in ischemic heart disease. Just a little overview, there was a big Danish national registry looking at this, showing a threefold increase of people with ischemic stroke as well as atrial fibrillation. There's also a UK database that also looked at that, looking at a 5.7 versus a 2.9 per patient year, 1,000 patient years increase of stroke. So taking us to today, this is an abstract from a couple years ago looking at early RA and the risk of having ischemic heart disease onset versus stroke. So here, they looked at 7,000 early RA patients, and they matched them 1 to 5, so they had 37,000 age-matched controls. And this study showed that there was actually no increased risk of stroke in early RA. However, they didn't really look at long disease duration. So does having RA for longer than 18 months make a difference? So let's fast forward to 2014. There was an abstract at EULAR looking exactly at this, looking at what are the clinical characteristics, the case fatality, and risk factors for people with stroke in RA patients. So this study, also very large, found that 640 out of almost 40,000 RA patients versus 2,000 patients in their comparator group of having ischemic stroke between 2005 and 2009. So basically, they also looked at traditional risk factors, and if you can see here in the graph, people with non-RA versus RA, that the traditional risk factors really didn't matter in terms of getting stroke. So the bottom line here is there was an increased risk in RA, and it couldn't be entirely explained by traditional risk factors. So there might be something about the disease itself in terms of stroke. And the reason I brought this up was because I think a lot of us worry about ischemic heart disease, while the area of stroke is actually less well studied, and how we think of differences in vascular damage with people with rheumatoid arthritis. So I was just wondering if people would actually change their practice a little bit in terms of looking at all different types of cardiovascular disease, including stroke. So I think, people are, understandably, rightfully, sort of on the fence. They know it's there, but I think the data still needs to be, looked at further for ischemic stroke.
I'm surprised the effect size is not bigger, but it's just the data are the data. Okay.